further ado, I really wanted to get an opportunity to introduce Dr. Sean Dugan, who is our speaker today. Sean is trained as a pediatrician, a child abuse pediatrician, and works as a forensic specialist with both adults and children for, I believe, 4 counties in Northern California, maybe more, I'm not sure. He is a dynamic speaker and really one of our foremost experts on strangulation and its presentation. And it's something that I think that all of us on the EMS side and on the ED side of things sometimes really miss the boat. So I'm really excited to turn things over to Sean.
Hey, thank you for the introduction, Jeffrey. I appreciate it. And good morning. My name is Dr. Dugan. That was a fantastic introduction. I'm the medical director for the statewide training program of California called the CCFMTC, or California Clinical Forensic Medical Training Center. So we do trainings on all forms of abuse from all ages. We just recently released a 8-hour DV training, how to do a standardized domestic violence exam, which includes the strangulation portion, neurological exam, neck exam, etc. And really that all applies to the pediatrics, because the same type of exam I do on an adult, I do the same type of exam on a child when it comes to strangulation. And we have a couple strangulation clinics here in our county for adults, and then another one for kids. And so I'm routinely in that. The adult one is obviously a lot more busy, and but the pediatric, there's quite a bit more pediatric strangulation, and it's being more and more recognized. So that's kind of me in a nutshell. I'm also a director of forensic services for our forensic care team, again, providing all types of exams from birth till death, cradle to grave. And I oversee a team of fellow MDs, nurse practitioners, PAs, as well as RNs. And I train all of my examiners. I don't care, what your degree is. All of them have the same expectations, same knowledge base, same skill level. There's some differences when you testify in court. If you're a clinician versus a nurse, you just got to be careful you don't say the D word, diagnosis. But short of that, it's everything else is exactly the same. And so yeah, it's really, this is everyone in attendance. This is well within your scope. EMS as well too. You're going to pick up pediatric strangulation. So thank you for being here. And so the title of this talk is Conjugal Disharmony, a hitherto pediatric strangulation and the forensic medical exam. And the reason I chose this and I chose this picture is there's an article that actually came out in, well, clicker here decided not to work. There's actually an article, oh, here we go. Apologize, there we go. Article that came out 1980, and credit one of my fellow child abuse pediatricians for finding this article and sharing it with me. But that was the title of the article, Conjugal Disharmony, a hitherto unto the cause of strokes. And it's amazing in this article, what happened was 2 women came in, they were of childbearing age, they weren't on any oral contraceptives, and they both had strokes. And they had big workups, and finally they discovered that both of these patients had internal carotid artery dissections with clots. So they had tears in the internal carotid arteries, and then they had stroked out. One being just a few days before, the other one being a few weeks before. And after kind of doing the $1 million workup, somebody finally asked them, hey, what happened? Were you strangled? And the answer was yes. And in fact, both women had been strangled. And so even in 1980, which is over 40 years ago, this author correctly, determined that, hey, if you have a young patient presenting with a stroke, you should ask about strangulation, and you should, do the workup. And by the way, this strangulation thing can cause somebody to stroke. The conjugal disharmony is a term I think is hilarious too, because that's what they used to call domestic violence, and this article I think originates out of England. And so it's very dated, obviously, but the author was onto something. And I just think I like to go back and read old literature. I think it's just kind of a fun little hobby. So again, no disclosures. That was a great introduction. I appreciate that. Pretty much if there's anything tied to abuse of any kind in Northern California, I'm usually linked to it some way. And then again, doing the statewide stuff. So some objectives, we're going to talk about recommended trainings, the strangulation clinic at our local CAC. I'm going to go through some mechanics, definitions. We're going to talk about some complications, do some quick photo review, and then I'll go over imaging recommendations, which, I'm going to lay out clearly, when we image, when we don't, what we recommend, just based on current evidence, some screening tools, and then finally we'll do some case review. So the Training Institute of Strangulation Prevention, I'm faculty, so full disclosure. I've done the basic medical portion, but I typically do the specialized kind of TBI section on traumatic brain injury caused by strangulation and head injury. So this is an older ad for it. It's not these dates this year in October, but if you go to their website and you could register for the next upcoming training. I think we're having one in August, I want to say. And so I strongly recommend it. It's multidisciplinary, so you can take your law enforcement, your attorneys, you could take your advocates. When I went with that makeup, and that's why we were able to open our strangulation clinic shortly after the conference. So I strongly recommend attending it, and you'll learn a lot. It's not just a straight medical conference. You learn kind of the whole spectrum. This is a picture of the CAC. This is actually, I was just there yesterday, and this is where we do our strangulation exams on demand. In the adult side, we have a clinic scheduled every week because there's just such a high volume of strangled patients or strangled adults. It's one of the most common injuries sustained during domestic violence. In fact, some studies show around half of patients will present with that. Peds, we need more data, but we know it's more and more common. It's being more and more recognized than it was previously. And so it's similar to a SART exam, sexual assault exam, in terms of the amount of time it takes. And that's because the history is really largely driven, or the diagnosis or screening, if you're an RN, is largely based on the history that's provided. And so typically what we'll do is the forensic interview will take place first, but there's limitations to the forensic interview, right? You know, they can't ask direct questions. They can't go through a symptom checklist. So once the forensic interview is complete, and of course, with, you know, once the rest of the MDT is fine with it, then we'll proceed. And usually 8 and above, we'll do the interview for the strangulation exam. And we go through the 502, which is a strangulation addendum we published this year out of California. And it's based on a form that we developed at my team called the Shasta. And so we go ahead and use this form, go through the symptom checklist, and it follows a very logical flow. Neck symptoms, brain hypoxia, brain anoxia, and upper body symptoms afterwards, and then neuro symptoms afterwards. So it's a very standardized, going through it, you know, line by line. And then we do the same, you know, physical exam, right? Standardized neck exam, standardized neurological exam. Then we render our opinion afterwards. And we'll talk about imaging, like I said, later. But if you're planning on doing these and you're planning on getting reimbursed, say by your county or whatever means you get reimbursed, I would plan for the same amount of time as a SART by the time you're done with your note. So really, I recommend teams charge the same amount. You know, to each his own, but that's just my recommendation if you're going to do it that way. In our county, we started a strangulation clinic in 2019, and we looked at data for DV felony filing rates the year before and the year after. And just in the first year, it was 160% of what it was the year prior. This includes both pediatric, you know, and it's mostly focused on domestic violence. But yeah, so I mean, you build it, they will come. And because of this, we've just had this huge, you know, recognition of it in our county. And many patients are getting more medical care than they would have had they not. And as a result, given we're in a mandated reporting state, more patients, you know, or more, excuse me, people are being prosecuted because of this. So what is strangulation? I'm going to be in court in about 3 hours on the coast after this. So I gotta drive to the coast and then head right into court. And what I'm going to say is exactly this. Strangulation, by definition, is really a decrease in blood flow to and from the head by means of external compression. That could be most often external compression of the neck, occasionally compression of the chest with a mix of something called mechanical asphyxiation. But in general, it's just decreased blood flow to and from the head by means of external compression. That's it. Choking really is more to do with the airway. So I choked on my burrito this morning, or I choked on a ham sandwich. Strangulation often involves compression of the trachea, and that's an important historical context or historical value when you get that from a patient, because we'll talk about a little bit, it denotes maybe how much force is being used. But in terms of strangulation, it's really just the blood flow. And I've had patients who are strangled to the point of unconsciousness who don't have compression of the trachea, especially when it's a posterior type of strangulation. So they're able to breathe until they lose consciousness. And that's because the blood flow is being compressed while the airway remains open. It's pretty rare, but you do have that happen occasionally. And there's really 2 types, manual or ligature. Manual is anything on your body, not just your hands. It could be your arm, your knee, you know, etc. And your ligature is anything not attached to your body. So a wire, cord, you know, rope, etc. Those types of things. Literature sometimes breaks out hanging separately. I don't. I consider hanging as literature, and most in forensic medicine do as well. But don't forget the chest. These are 3 cases. All 3 had confessions. And in this case, all 3 suspects would basically crush the kid's chest, and the child would lose consciousness within, you know, just a few seconds. And so what was going on there is, in addition to compressing the lungs, that's called mechanical asphyxiation, it was likely that they were compressing the aorta, or they were compressing the, you know, internal carotids, or, you know, whatever have you, the lower aspects of it, but it was likely the aorta. And so in the process of compressing, many of these infants had multiple rib fractures. And so each of these children in this case had rib fractures. And we're going to talk about the bottom right case as one of the cases in case review today. But I showed a picture there, and it might be a little hard to see on the monitor, but the photo on the right is the same as the left. It's just the oblique angle, and you can just see multiple rib fractures there with healing calluses that were present. So especially when dealing with infants, consider, especially if you have some indicated physical exam findings consistent with strangulation, consider the fact that it might be an infant that had its chest compressed. And then that's especially, you're going to go looking for those rib fractures, your skeletal survey, because that is sometimes something that we'll see. And if you don't have anything in the acute skeletal survey, make sure you do it 2 weeks later, because sometimes they don't show up till a couple weeks later. Basic anatomy. It's really not rocket science. There's only a few major blood vessels we care about. Your carotids are on both sides. Those bifurcate at about the level of your chin. Almost, it's just more or less right about there. So you got your main, carotids there, then they bifurcate into internal, external. So, majority of the strangulation is going to happen over the main body of the carotid. And then your vertebrals. Your vertebrals are the main artery in the back of your neck. They only supply about maybe 20% of the blood, give or take, and they're covered at certain parts by your spine. So depending on where the compression is in the neck, it may take a little bit more force to compress. And then you have your jugulars, which are very easy to compress. It doesn't take much force. And those are on the front of your neck there. Those are actually technically the internal jugular. You do have an external jugular, but it plays virtually no role in blood flow going from the brain back to the heart. And you also have the vertebral vein, which also doesn't play a big role in, pumping brain or blood from your brain back to your heart. So I don't even, mention those two. It's just really these three blood vessels that we talk about in strangulation. And then your anterior midline structures, your hyoid bone, your thyroid cartilage, which is your Adam's apple. Everybody has one. Your cricoid cartilage, which is just below your Adam's apple, and then your tracheal rings. And those are common sites for tenderness after strangulation. There's a study, there's an article, and it came out over 100 years ago. And it looked at the different types of forces that are used. And what's amazing is every article has come out since then, even as recently as 2009, where they took cadavers and they used ultrasound and MRI to determine the forces, all have those same forces in adults. I mean, it's truly amazing that in the span of, over 100 years, you're talking like 110 years, whether it was a crude experiment hanging a cadaver and, putting a thing on its neck while you're pumping fluid through its veins and arteries, or something really fancy using, ultrasound, MRIs, etc. They've determined that those forces are about the same. And keep in mind, they're approximates. What's going to take to compress your neck may not be for mine. And one thing I always point out when I do my child abuse strangulation exams is that there isn't any values for kids, but it's likely that it takes less force in a child due to the size of the child than it would an adult. And I think it's really important for everybody who's watching, if you're doing a strangulation exam on a pediatric patient and you are writing an assessment up, and that's within your scope, to make that point, because we don't have studies, but presumably it would take less force in a child than it would an adult. And so the forces are, for the jugular, 4.4 pounds of pressure, carotids are 11, and the trachea is 33. So if somebody says they can't breathe, that's a huge marker, because that means that's more than enough force to compress the carotids and the jugulars, and likely the vertebrals. The reason the vertebral range was so large, again, was because of the transverse process of the spine. So certain parts of that bone is covering that artery and giving a little bit of protection. That 2009 study, though, found that many of the cadavers had a 2-centimeter segment exposed near the jaw. So actually, it's technically more efficient to strangle someone way up here or way down at the bottom of their neck. Regardless, though, when you look at relative, how much force there is with a handshake, etc., it is not much to compress the neck. So you got a child who has likely less forces than this required, and you have, say, a huge adult or normal-sized adult, applying pressure to the neck. It's just not going to take much to occlude the blood flow to and from the child's brain. And other studies have looked at how long that takes. And so in general, it takes about the average about 5 to 10 seconds for loss of consciousness to occur. No one's obviously done that in children, but this is for adults. And this has been done with experiments in the 40s where they actually tested it on people. They actually strangled people with a cuff, a very well-designed technically and very specific experiment they were doing for the military, all the way up through, last year or 2 years ago when they studied MMA fighters and how long they took to strangle, lose consciousness, and studies from the 80s and, even early 2000s on cops when they would do the vascular neck restraint. So no matter whether you're in the best shape of your life or, a combatant, or you're volunteering for this thing, or you're out of shape like me, we all go down within the same 5 to 10 seconds. All of our brains are bound by those same basic principles of physiology when it comes to limitations, how long we can go without oxygen. And 2 big studies on stroke determine what rate we start to lose brain cells once the oxygen's turned off. And so one that came out in 2005 called SAVOR, which is called Time is Brain. And I don't think there are any neurologists in the area here or in the talk, but if you want to impress your neurologist, or say you're out one night and you're single and you're at a bar and you see the most beautiful, attractive neurologist of whatever you prefer of your life, if you would just whisper time is brain, I guarantee you will have a 5-hour conversation with that neurologist that night. And all they're going to do is talk about, because that's all they ever talk about. Even the more recent studies published, it's always reference time is brain, whenever it's a study about anoxia. So, just a little tip.
Sean,
yes.
One question for you there, because you've been emphasizing that strangulation is a blood flow problem, but when you've just talked about people passing out, you've talked about lack of oxygen. You're saying lack of oxygen because of the blood flow, not because trachea is being compressed, correct?
Absolutely correct. Yeah. So it's the lack of oxygen because the blood's not going to your brain, not the air. Because when your airway is compressed, it's think of kind of like holding your breath going underwater. Your body has a reserve of blood flowing through it. And since your heart's still pumping, that deoxygenated blood in your brain gets shifted down to back to your heart, distributed to your body, and then your other blood within your body that still has oxygen gets shifted up to your brain. That's what allows us to hold our breath. That's what allows us to, dive, or, you're going through the tunnel with your kids, everybody hold their breath. That's because you have those reserves. And on top of that, if you were to take a deep breath before you held your breath, you have oxygen reserves within your lungs. But when you apply pressure to somebody's neck, you cut the head off from the rest of the body's blood. So you don't have that oxygen reserve anymore. And so that's why you lose consciousness so quickly, because the oxygen in the blood that's in your brain is no longer there. Our brains consume a ton of oxygen. In fact, about 20% of everything we breathe gets used up by the brain. And so that's the reason why, without having that extra reserve to your body to come up to your head, you drop within 5 to 10 seconds. But I appreciate you clarifying that. Yeah, it's all about the blood flow. The trachea is an important marker and, of course, an important part of our body. But when we're talking about strangulation and the loss of consciousness, it's all about the blood. And funny story too, there's actually, I like to read old literature, and there's some cool literature in the mid 1800s where forensic pathologists started to stipulate this, then they were looked at as crazy. Like, no, it's the airway. When we hang people, that's why they die. They lose consciousness because they can't breathe. And it was some pathologists who just, starting to figure out, like, no, I think it's actually the blood flow, guys. So anyway, a little historical perspective there. But I hope that answered the question. And going back to that Time is Brain study, it's a classic study. And in 2019, Desai came out with a similar study. And it's amazing. Here you have 2 different neurologists, teams, 2 different sets of patients, 2 different locations. Everything is different, right? And Desai's author came down to almost the exact same rate. I mean, it was almost exactly the same as the SAVOR study. And so what it really showed, again, is despite all of our differences in personalities, our different talents, whatever, despite the fact that our bodies can be vastly different in their abilities. You have Olympic athletes or you have couch potatoes, right? Our brains, doesn't matter. Our brains are all bound by those same basic principles of physiology. And so these would extrapolate backwards towards children. I mean, no one's going to strangle children and watch how long till they lose consciousness. But, it's reasonable that it takes approximately the same amount of time and that children would lose, brain cells approximately the same rate. And keep in mind, you're born with your brain cells. So you're born with your full set of brain cells, and you hope to live to 85 or 90 and die with that same set, unless you're strangled or, brain damage along some part of the way of your life. But so they have that same amount of brain cells as well, too. This is a timeline of events, and it's from the Training Institute on Strangulation Prevention. This is based on several studies. Again, the Rosen study I mentioned, but also some newer ones. Annie Savageau, she's a forensic pathologist in Canada, and she's watched videos of people being hung, and either through autoerotic fixation that goes wrong or judicial hangings. And so this timeline of events was developed based on that. Some of the important markers are the loss of consciousness, 5 to 10 seconds, which is the average in one study was 6.8. And then you have your urination at 15 and your defecation at 30. So the trial I'm going into today, the patient did disclose urination. She noticed after the strangulation, and she did disclose loss of consciousness, but she doesn't remember the urination. So we'll see if that gets brought up. And the old literature used to talk about death occurring in 3 to 5 minutes. But again, that wasn't really based on hard evidence. It was just sort of one of those things that forensic pathologists said in the 1800s, and it just got carried through into the 1900s. But in modern studies and with the availability of video, we know that death occurs within 1 to 2 minutes. And so, and I can even share with you a video if you want of a man being strangled, and he's killed within, he was strangled for 72 seconds, flipped over, full resuscitation efforts, never came back. So 1 to 2 minutes is all it takes, full strangulation, full anoxic brain injury for you to be unrevivable. Petechia is not on this, and that's actually a picture of a child right here. There's a 3-year-old. Petechial hemorrhages aren't listed on here. Petechial hemorrhages are basically when blood goes to the head but can't return to the heart. So you have enough pressure to occlude your veins, but not enough to occlude at least one of the arteries. And so your heart is working aggressively to pump blood into your brain, but your brain can't pump the blood back down. So the little tiny capillary beds that are in our tissues fill up and then burst. And the areas that have less supportive tissue, like your eyes, the conjunctiva, the white part, or the eyelids and areas around it, will start to burst first. And so that happens around 15 seconds. So this is also an important timestamp. If you have a child present like this one with strangulation disclosures, this is huge because this tells you approximately how long the strangulation lasted, 15 to 30 seconds or longer. And this is that study I mentioned earlier for Rosen in 1943. It's just incredible. U.S. Air Force contacted a group of scientists because pilots were flying over, dropping their bombs, flying back up over Germany in World War II, and they would lose consciousness because they were subjected to 7 to 9 Gs of force. And so the Air Force wanted to develop some kind of special spacesuit or helmet or something. And so they went to a prison and they recruited volunteers, and they tested it out. And so this experiment, while it sounds crude, it's very specific. It's very well designed. The authors go into a lot of detail. And when you read the symptoms that the volunteers gave and disclosed, it's just eerily creepy because it's the same symptoms your patients will tell you, both pediatric or adult. And again, that's because all of our brains kind of bound by that same basic physiology. And then, as I mentioned, there have been other studies since then. I've looked at this, and every single one, 5 to 10, 5 to 10, 5 to 10. It's pretty consistent across the board. This is a video. Don't recommend it, but Tashi Brown, this is a strangulation video that I was mentioning. And so I hate watching this stuff, but I did because if I'm asked on the stand, yes, I've seen a person die within 1 to 2 minutes of strangulation. That isn't just something that's made up. I mean, there's actual video evidence out there that people can die, healthy young adults can die within that short amount of time. And some complications, there's a lot, but by and large, the most common long-term complication that I see is the effects on the brain if the patient loses consciousness. And in my clinic, there's just almost this demarcation. You have patients who are taken just up to that point but don't lose consciousness. They fare much better. In fact, they don't often report the chronic memory problems versus the patients who lose consciousness. It's just amazing. It's like flipping a coin. And this is taking into account other forms of traumatic brain injury as well too, like blunt force head trauma. But that, by and large, the memory problems is what I see lasting the longest. And you can imagine a pediatric patient, right? It can affect their grades at school. It can affect their behavior at school. It can affect their interactions with their family, interactions with their peers. And it's complicated because their brain's not done developing, right? They still have developmental stages to go through. And if they've had an anoxic brain injury, they're going to have that as a preset before they go into those next stages. So again, it's by and large the most common thing I see in someone who's strangled. The point of loss of consciousness, it dramatically affects their course afterwards. The hoarse voice, the sore throat, etc. They can have that for weeks, sometimes months. You can have more serious things like carotid artery dissections. That's much less common in children, but that's something that's technically possible. And you can have other types of fractures in the neck. So lots and lots of complications from strangulation. This is a patient I evaluated in the ER, and you can see I blacked out her eyes, but she has bilateral subconjunctival hemorrhages. She has multiple petechial hemorrhages across both areas around the eyes. She even has a little bit to the nose there. Just, pretty significant amount of petechial hemorrhages present. When she closes her eyelids, you can see bilateral petechial hemorrhages there too. Sometimes the petechia coalesce around the lower eyelid. They almost look like a blue or purple. It's not bruising. That's just the coalescence of the petechial hemorrhages. And you just see bilaterally across her face there. Inside her mouth, so she had petechial hemorrhages to the palate. Depending on your resolution, you can probably see that big bright red one to the left side of your screen, but she has several kind of on the hard palate there too. And then just, pretty significant conjunctival hemorrhages at the right eye. And a large one on the left. So CT imaging, we actually don't recommend routine imaging on children. I just published an article, it was a commentary that came out this month about doing imaging for adults. And there is large studies of blunt cerebrovascular injury in adults. They include a small amount of strangulation patients, but the rate of carotid artery dissection is the same in those large studies and the practice management guidelines as it is in the small strangulation cohorts that have around like 200 to 300 or 400 patients. And so we do recommend in adults doing CTAs. And what the literature has shown for adults is that even the best clinical screening guidelines miss anywhere from 30 to 40% of vascular injury in adults. And so they do recommend doing those in adults, pretty liberal screening of CTA. But in terms of children, I don't routinely perform it. I don't recommend it being done routine. There just isn't enough evidence yet. If you think about it, children's tissue is a lot more pliable, less likely to fracture. Think about like a green stick fracture, for example, right? You don't see those in adults, and that's because the child's tissue is more plastic and more malleable. And so that could change someday. We just need more studies, but right now I don't recommend it routinely. The radiation risk is minimal in an adult, but it is more significant for a child in terms of the thyroid. So that's just my opinion, but I believe case-by-case basis makes sense. So if in your clinical judgment, you think this child needs a CTA, get it. That's your clinical judgment. But I don't recommend it just routinely or liberally on all kids. And it's not just based on this only study. There's other studies, but even in this study, which is, had about 66 patients, there were other injuries present. You can see the craniocervical injury there. That's that distraction, that separation. You can see from the skull, from the neck, pretty nasty. The soft tissue injury, of course, and 13% had cerebral edema. But again, no carotid artery dissections. Again, this doesn't mean I won't be saying something different in the future, but yes.
One of the questions in the chat is, when do you recommend getting the imaging in kids, and specifically if there are physical findings of petechiae, does that kind of push you more towards getting imaging in kids, or what is that individual decision making?
It's a good question. It doesn't. I think if you have a child, it's going to be case by case. I think if you have a child that presents with tunded, altered mental status, or really significant head and neck trauma, I think it's reasonable to consider it in that case. We know blunt force injury, in addition to strangulation, can cause vascular injury there too. So I'd say case by case. For the most common, strangulation patients we see where they're strangled by a parent, or if they're a little bit teenager, maybe a partner, most of those don't probably warrant the CTA. But yeah, it's hard. There's no clinical screening guidelines for kids. So I think for me, if my clinical judgment, it would be significant, injury, right? Significant injury to the head or neck, a patient with neurological compromise, anything like that, I would be more apt to consider doing the CTA versus, the patient you see who disclosed strangulation, maybe a day ago, maybe 2 weeks ago, doesn't have any of those other symptomologies or presentations. So, and it's just gonna be case by case. And I wish I could give you better than that. And I have done CTAs on kids in the past, and as we've gotten more literature review done, that's when I've changed, if you will. And for adults, I just 18 and above. There is one vascular study that went down to 16, but they didn't differentiate their positives. And it was a large study. It was like over 4,000 patients. And so it would have been valuable to see the 16 to 18 group if they had any positives, but they didn't. So. And then this is the adults. I'm not expecting anybody to memorize the screen, but again, in adults, it's pretty amazing across the board. 1% to 2%, 1% to 2%, 1% to 2%. There was one outlier at 15%, but that was a very the way they chose. They only imaged 6% of their patients, and the ones they chose to image were like very, very injured. So, I can think it's kind of an outlier. So yeah, again, it just makes sense. We see blunt cerebrovascular injury from all forms of trauma, about 1% to 2% of all cases, and that includes strangulation. And that's just for adults. There's a new addendum came out in the state of California. I developed this with some of my colleagues, and it's similar to a screening tool we were using here in Shasta County. And this is for the head injury addendum. And I know we're talking about strangulation, or excuse me, this is a strangulation addendum. We also have a head injury addendum. And I developed this with the thought of one of my SANEs, one of my nurses doing this assessment, because there are other strangulation assessments out there. But when you go to the symptom checklist, it's just like a smorgasbord. They're just in a random order. It'll ask you about neck symptoms, then it'll ask about a anoxic brain symptom, then it'll go back to asking you about like a neck symptom, and then it'll ask you about a brain hypoxic symptom. And I never understood the flow. And so when we opened our strangulation clinic, I always taught my examiners to, no, you go in the order of neck, then brain hypoxia, then brain anoxia. And we were doing that. And I realized that it's not going to be helpful to have an assessment out there that has a smorgasbord and tell people go with the first and then the fifth and then the 10th and then come back to the second. Like, it just makes no sense. So we put the symptoms in a chronological order to do a logical flow. And that's also helpful too, because patients who lose consciousness from strangulation often don't remember losing consciousness. So there's a gap in memory they may not be even aware of. And on top of that, they have a trouble remembering the sequence of events. So going through the logical progression here helps to really reorder those events correctly. And you'd be amazed at the what patients will recall when you stick with that kind of logical flow, versus if you just say, hey, what happened? You know, you get it all over the place. If you're a clinician, this will allow you to diagnose traumatic brain injury. If you're a nurse, an RN level, you can screen positive for. And sometimes I think it's a little intimidating for RNs, but what I tell them is there are tons and tons of stroke assessment tools that are used in every ER in this country that's a stroke center. The BFAST, there's so many of them. I downloaded a cool PowerPoint the other day from an RN who presented on it, and I was just like, wow, there's at least a dozen different screening tools on here. What the job of that triage nurse is to screen the patient. And if the patient screens positive for potential stroke, what do? They hand it off to the stroke team, they refer. That's the same.
Aurora, did you brush your teeth? Joe, did you have her brush your teeth?
I think somebody's unmuted.
I told you.
The RNs will screen, someone's getting ready for school. The RNs will screen positive, right? And my RNs will then refer. Either, you know, if you have neurologist specializes in it, great. More often than not, that's lacking in the areas, at least that are served in my area. And so occupational therapy can help these patients, or refer them back to primary care. But yeah, again, you're not diagnosing, you're just doing a screening tool. And the analogy of the stroke is perfect because that's another type of brain injury. And this is done routinely in hundreds of ERs. There's hundreds of stroke centers that are across the country. So it's not outside your scope to use if you're an RN. You just got to be careful. You're not diagnosing the patient, right? Just like you're not diagnosing that patient with a stroke in the ER, you're saying, hey, I'm concerned you may have had a stroke or might be having one. Please go here. And same thing this, hey, I'm concerned you may have had a brain injury from this strangulation. Please go here. And this is the head injury addendum. It's similar, guys. It's also similar to the ACE, which is the acute concussion evaluation developed by the CDC. And there's a lot of our inspiration, but it's the same thing. Mechanism of injury, neurological symptom equals TBI. And these forms are free, by the way. They're on the CCFMTC website. I was reviewing a DV protocol actually for New York and a hospital in New York, and they literally copied this word for word. I mean, it's just like word for word. There's no change. They just changed the logo and it's fine. You know, all I care about is patients are being screened and accurately receiving, adequate medical care. So if you want to go on the website and, use this assessment, be our guest. It's completely free to the public. So case discussion. What we have here is a 2-month-old male, and this patient was brought into the ER. So what happened was the kid went to primary care Friday. They did an x-ray of the leg because they thought it looked swollen. The results didn't come back till Monday. For those of you who work in a rural setting, unfortunately, that's just how it is sometimes. And so they sent the kid into the ER. This is a 2-month-old now with a leg fracture. And so they went ahead and called me. And it was ironic. It's kind of like this situation, except the opposite. I was driving back from Modoc, which is a county that's like another 3 hours away in the northern direction. And I'm about half hour to an hour out, and I get a call from the ER, and they said the kid's stable. So they said, all right, hold the kid. I'll be right there. And so I come in, and we initiated the child abuse consult. The ER had noticed some findings, and this is what I took pictures of. So if you look at the patient's left eye, you can see a subconjunctival hemorrhage that's on the medial aspect. It's kind of towards the nose. So if you're looking at the picture on the left, you can see that kind of left eye. The picture on the right isn't inverted. If you look at the picture on the right, you can see there's a red line. And at first glance, it might look like a subconjunctival hemorrhage. But when you zoom in and get a little bit closer, it actually crosses over the corneal edge there. So this is something that's actually on the cornea, not on the conjunctiva. And this is the only cutaneous finding this kid had. This is it, just this kind of curvy linear. This is actually a red ecchymosis. So helpful tip. I do a lot of case review for other counties that have examiners, and they'll say erythema, but they don't determine whether there's blanching or not, because you can have red bruising that doesn't blanch. And so this did not blanch. So this was actually a red bruise. But if you don't make that determination if something blanches or not, we'll never know. The world will never know. And that's a big difference, right? Because erythema is non-specific, ecchymosis is specific. So recap that. If you see something red, a red mark, press on it. If it doesn't blanch, it's probably a red bruise. If it blanches, it's just erythema. So we did the skeletal survey. We went ahead and did a CT of the skull. The head CT revealed a left parietal skull fracture with possible subdural hematoma. And so we went ahead and had the skeletal survey read. And this kid holds the record in Northern California. I haven't met anybody yet across the country who beats this kid, but this child had more fractures than any other child I've ever treated. But if you just look, there's this laundry list of fractures: skull, shoulder, ribs, just about every, like the acromion, just about like every child abuse specific fracture you can think of, this child had, and in total 27 fractures. I had actually had another kid with 26 fractures in a neighboring county, and it wasn't long before this kid took the record. So just incredible. And on the eye exam, what that was it was a corneal laceration that had neovascularization. So the cornea had been lacerated and the body was healing. And so it actually had like blood vessel formation within the edge of the cornea there. That's what we were seeing at the time. So I left the hospital, and it was, I don't know, whatever, god awful time of night. And I get a call from the investigator, and the investigator says, "Hey doc, can you come talk to this mom?" The mom of the patient, because they were interviewing her and they were worried that she was just going to leave. And at this point, you know, they weren't sure if they're going to arrest her. They weren't sure what they were, you know, going to go on, and she wasn't cooperating with them. So I drove over to the police station, and I've never been inside a like interrogation room. You know, I've been in the police station for meetings, but you know, I've never been in trouble with the law or anything. And so I come in there, and man, it's a scary place. Like the room, it looks like kind of like this, and it's like really intimidating. And so I go in the room, and the mom, you know, she's kind of just like looking down, and she's not talking to the investigator, won't give up her phone. And I explained to the mom that the child had all these findings, right? The child had the laceration to the eye, the hemorrhage on the other side, skull fracture, brain bleed, multiple fractures throughout the body. And she tells me about 2 to 3 weeks ago, the kid had a positive glass test. And this is what her words were. She says 2 to 3 weeks ago, he had a positive glass test. And I'm like reaching through the, like every nook and cranny of my brain, trying to remember what a glass test is. And I don't know what it is. I've never heard of it. So I asked her, what's a glass test? And she tells me that's where she took a glass like this. She placed it on the child's forehead where the red dots were, and the dots didn't disappear. So what she was describing was some type of red dot that wasn't blanching, and then they disappeared a few days afterwards. So she was describing what sounded to me like petechial hemorrhages. And it was at the same time that she noticed that subconjunctival hemorrhage. And I knew from the x-rays, it was the same time as the age of the rib fractures. The rib fractures are approximately 2 to 3 weeks old, based on what the radiology read, because they already had a bunch of callus formation. And so I really told her the only thing that's going to cause subconjunctival hemorrhage, petechial hemorrhage in the setting of multiple rib fractures is strangulation, is mechanical asphyxiation with strangulation. And that's when this whole thing took a turn. I remember there was this moment of silence, and I mean, you could hear the, you know, butterfly flapping its wings across the world. I mean, it was silent, and the mom was looking down the whole time. So the mom then looks over the investigator, says a 4-letter word to this guy, F this guy, throws her phone at the investigator, who's this like really buff cop that I know. She's in really good shape. She catches it real quick, and she immediately becomes compliant. So it completely turned this whole thing around. And so I'd done my part. I'd explained the results. I left. The law enforcement then were trying to find the other child because of the infant had sustained so much injuries. They transferred him to the ICU down at UC Davis. And there was another child a little bit older, like an 18-month-old. And so they brought that child in for a scan as well, too. By the time they found the kid, it was so late at night, I went home, I went to bed and then came back the next morning. And to my surprise, the mom was actually in the room at my hospital. I would assume she would have gone down to UC Davis to be with the baby, but she couldn't get a ride. So she stayed at the local hospital here. And it had come out in her interview that she was strangled by the same suspect. So I said, hey, like, I run a strangulation clinic. I do not only kids, I do adults. Would you like a strangulation forensic exam? And she said, sure. So here I am doing an adult, female strangulation exam in the pediatrics department of our inpatient hospital. And sure enough, he had been strangling her in very similar mechanisms without the rib fractures, obviously, as he had been doing the infant. And so, yeah, He ended up facing several charges, about 14 of them, but as part of a plea deal, some of them were dropped. And he pled guilty to 1 count of attempted murder, 1 count of mayhem, 3 counts of child abuse, great bodily injury, and 1 count of domestic violence. And so he's serving a 20-year sentence right now with that plea deal. So I never had to testify. But, you know, this is one of those cases where having the adult be able to say the history made a big difference. For any of you who do child abuse, this is easily a case where they could have got some expert to come in, some child abuse defense expert, and say, well, maybe the kid has rickets or has Ehlers-Danlos, or did you work the kid up for this stupid syndrome that nobody has, right? But what was damning was the fact that the mom could testify that he was doing the same thing to me, and you know, had the similar types of injuries, is what really made a big difference, the prosecution said in this case. And so it goes back to one of my tenets, which is, you know, if you're only treating child abuse, you're only treating half the problem. There is so much domestic violence out there. And, you know, everything we do in child abuse in terms of evaluation, treatment, et cetera, is the same for adults. The adults have the same pattern injuries. Adults have the same types of bruising. The difference with adults is they can usually tell you what happened. So it actually makes it a little bit easier. So anyway, just throwing that out there. And for most states, for most clinicians and most RNs, you're not bound to a certain age group. There's certain exceptions with nurse practitioners, but typically speaking, you can see an adult. In California, I'm a licensed physician. I specialized in pediatrics, general peds, and then I specialized in child abuse, but it doesn't limit me to only kids. I can see adults. So just throwing that out there. Case number 2, older patient, 14-year-old, came in for a SART, a sexual assault exam, or a SAFE exam. And she'd been out walking with her friend, and they know each other for years. And just all of a sudden, he just assaults her. And so it was a sexual assault, and the patient was in the prone position. So he was behind her and he was strangling her, and she would report kind of going in and out of consciousness constantly throughout the strangulation. Why I like this photo is she's a redhead and she has freckles. And so you can see there's petechial hemorrhages intermixed with her freckles. And it's easy to see or distinguish where the petechia are, but I like to show this because of the freckles. And so multiple petechial hemorrhages to the bilateral eyelids and surrounding eyes, and pretty significant subconjunctival hemorrhages bilaterally. And this girl was in high school, or I think 8th grade or 9th grade. And she was so embarrassed. She was just so distraught. And so I wrote her a note to be out of school until these things resolved. I was like, no, you can absolutely stay home for a month. But yeah, just you really floored subconjunctival hemorrhages. And this was the only finding on her neck, just this kind of non-specific red microhemorrhages / ecchymosis. So those are microhemorrhages, those little red dots. Those aren't petechia. Those are caused by the actual tissue trauma, the blunt tissue trauma. And they can have a non-specific shape like this. In case number 3, 14-year-old strangled by her father. So this is a child abuse case. She ended up describing that her father had basically pinned her on the ground by her neck. And she reported she could feel her neck being squeezed, but he was also leaning on her neck. So her neck was also being compressed against the floor. So there's kind of 2 mechanisms of compression there. And she reported blurred vision, decreased hearing, dizziness, and she felt faint. She denied a loss of consciousness. But again, we used that logical flow of the form, and we ended up establishing that there was a memory gap between her feeling faint and her having the vision and hearing changes, and at the point at which all pressure was removed. And so she doesn't actually remember her father letting go. So there is a gap in her memory, which is a loss of consciousness. And this is her findings. This is the right side of her neck. So the left side was compressed against the floor. This is the right side. And if you look, you can see multiple red linear ecchymosis. These don't blanch. They're not erythema. And so anytime I see something red, I again go see if it blanches or not. And what it is those are the areas between and around the fingers. When you compress someone's neck, or even if you hit somebody really hard, the pads of your fingers displace the blood underneath the tissue. So the blood obeys the laws of physics and goes around the fingers. So the areas between the fingers and around the fingers get a sudden surge in capillary pressure. So those are the capillaries that burst. And so that's why when you're doing these types of exams, you'll see those kind of multiple parallel linear ecchymosis. I tell you, same pattern injury you see in adult patients as well too. But this is a classic, pattern child abuse injury as well.
Sean, one of the questions that's popped up is how soon do petechiae show up after an event?
Great question. They're usually pretty soon. So bruising can take, anywhere from 24 to 48 hours. No one studied the rate on petechial hemorrhages, but if you think about it, the blood vessels are bursting in that moment. And so you can take, within the day or so for them to really develop and really show, but you can sometimes see them a little bit closer to the event. So general rule, within about a day or so for the petechial hemorrhages, and they're usually gone within 72 hours. The conjunctiva, a little bit different though. The eye ones, those can actually last, if they're in the white part of the eye, that can last up to 3 weeks. And so like that infant I saw, for example, it had been 2 to 3 weeks after the event, and all the petechial hemorrhages are long gone, but the subconjunctival hemorrhage was still there. Good question. And this patient, I just say, can you see a petechia? You probably can't. I mean, you're looking at a gradient monitor, but she has a single petechial hemorrhage to the right side of her face. Would I make a big deal about that by itself? No. But I did her eye exam. And this is sometimes where examiners fall short if they don't actually take the time to lift the eyelids up and down, have the patient look in each direction to actually look for a subconjunctival hemorrhage. And lo and behold, she had a subconjunctival hemorrhage on her left. So she not only had that single petechia on the right side of her face, but she had the subconjunctival hemorrhage on the left. So because she had the subconjunctival hemorrhage, I felt calling that thing on the right side of her face petechial hemorrhage. And so that would indicate during this strangulation, at some point, one of her blood vessels was open for about 15 seconds to allow those to develop. And then at some point, 5 to 10 seconds, a full occlusion occurred that resulted in the loss of consciousness. And I know I testified in that case, that one blood. Last case, a 13-year-old male, strangled by his own.
Before you get into that, one other question that popped up was, what questions do you utilize to try to assess loss of consciousness and regaining consciousness in the victim? How do you tease that out?
It's a great question. So when we use the 502, the strangulation assessment, or the Shasta, we go through the neck symptoms first. And this is after we've established what happened, right? So we'd ask where they were, what was used on their neck, did they use both hands, did they use something else, etc. So we go through those questions. Then we get to the next section and we ask if they were unable to breathe. If they say no, then we ask, was it difficult to breathe? Those are two important markers. Most patients, in my experience, just report being unable to breathe because that's just how a lot of strangulations happen in an abusive type of situation. And then we'll move on to the brain hypoxia, so the low oxygen to the brain symptoms. So those would be, seeing stars, tunnel vision, vision going black, any decreased hearing or hearing changes, any feeling faint, lightheaded, disoriented, etc. That tells us if the patient says they were unable to breathe or had difficulty breathing, and then they had those brain hypoxia symptoms, what that means is there was low oxygen to the brain. So blood flow is being occluded to the brain is starting to shut down. Then we move on to the brain anoxia section, which is loss of consciousness. So we'll ask them, did you lose consciousness? If they say yes, that screens positive for a traumatic brain injury. That's a diagnostic traumatic brain injury. If they say no, then I'll pose the next question. And this is where it's really important. And I'll ask them, from the time pressure was applied to your neck and you were unable to breathe and you experienced those symptoms we just talked about, the vision changes, the dizziness, hearing changes, feeling faint, etc. To the very end, when all of the pressure was gone from your neck. I don't say to the end of strangulation, I say till all the pressure was gone from your neck. Do you remember every single moment when you replay that memory? Or are there any gaps? And let the patient replay the memory. They might take 10, 15 seconds. You just sit there quietly, maintain eye contact, don't click your pen, don't chew gum, just wait for them to answer. And if they deny a memory gap, okay, then that's not a loss of consciousness. But if they had a gap in memory between the time of those brain hypoxia symptoms, the dizziness, feeling faint, etc., to the very end while our pressure was gone, that's positive for a memory gap. That's positive for loss of consciousness. And that's a patient who does not remember losing consciousness. I don't have it in this talk, but there's anecdotal and research-based evidence about patients who are strangled and don't remember losing consciousness. No one's actually published the rate though. And so I'm actually about to submit, we're almost done finishing the data, a study on adults, over 200 adults, and the rate that they report in the preliminary data is around 40%, meaning about 40% of patients will deny loss of consciousness, but actually have a memory gap. And that's a huge amount. So we're going to stress in our paper that people really need to not just ask, did you lose consciousness, yes or no? You really need to go through the logical flow of a strangulation assessment to determine if that memory gap is present. And then we're going to release that same study for kids. I have about 30 kids aged 8 to 17 that we've done the Shasta on, and same questionnaire. And so I haven't calculated their rate yet, but prelim data in the beginning looked like it was around the same 40%, but I haven't calculated in a little bit because I'm focusing on the adult study first. So Yeah, so just download that form. I can email out the link if you guys want, and just go through that logical progression. I haven't gone below 8. I think, I'd start to worry about the kid being able to answer. But if you think about it, like 8-year-olds come to the doctor all the time. I was a pediatrician all the time with soccer injuries, with football injuries, and you ask them symptoms, right? You go through that symptom checklist from the CDC, and you ask them, and you make a diagnosis of concussion or brain injury based on that. There's no reason why they can't answer a strangulation assessment. But use your judgment. Developmental delays would obviously take that into effect. If you have a delayed 8-year-old, you may not want to do that. But yeah, I feel comfortable 8 and above as long as they've gotten the forensic interview at a CAC, and you've cleared the rest of the team. So I hope that helps. And yeah, like I said, that pediatric study probably won't be out for a couple years. I got to finish this other one. Last case.
I do have a quick question for our EMS providers out there. If they are responding to a scene, at what point would they say it's okay to stay home versus bringing them into the hospital?
Good question. In my opinion, if you have a pediatric patient that's strangled, I would have them all evaluated. Absolutely. This is a child abuse event anyway, so they should be getting a forensic medical exam. So for me across the board, any pediatric patient, if you're worried about strangulation, just bring them in, have them evaluated, get the child abuse consult, and kind of go from there. For the adult, I recommend all of them get evaluated too. I've had cases where I interview the patient in the adult side, and there maybe wasn't very much pressure to the neck, but we end up finding other forensically relevant findings, or there maybe have been other brain injury from blows to the head. So I do recommend all patients, if there's a concern or history for strangulation, you're not going to have the time in the field to spend doing the full assessment, doing a forensic exam. You don't have the 2 to 4 hours, right? You can't stay there for 2 to 4 hours. So bring them in, and especially if it's a pediatric patient, I would bring them all in, get them evaluated, and make sure you get the child abuse pediatric consult done too. Good question, though. Good question. And then last case, case number 4 is a 13-year-old male strangled by his uncle. So this is another child abuse case. And he disclosed having the uncle place his hands around the front of his neck, and then he was lifted off the ground. His uncle's this big guy. And so he lifts this boy off the ground. And at one point, he kind of like shoves him into a dresser, and he's kind of shoving him here and there. And the patient actually reported experienced the vision changes, dizziness, feeling faint, and then he did remember losing consciousness. He has some interesting findings because these are self-defensive wounds. So he actually does remember before losing consciousness, he said he was digging in, trying to pull his uncle's hands off his neck. So typically when you see these vertical scratches like this, vertical, not scratches, excuse me, vertical abrasions or vertical microhemorrhages, those are actually self-inflicted usually. And that's just the person trying to pull, the patient trying to pull their hands off their neck, or the rope off their neck, or the belt, or whatever's being used. So that's a pretty, you don't see that super often, but when you do that, especially if it's vertical, I would be really considering this might be self-defense wounds. What's interesting about this case is he has a hoodie mark. There's plenty of shirt collars out there in the medical forensic textbooks, but this is actually a hoodie. So that line going down like this is actually the hoodie. And he describes it. He said, I could feel the hoodie cutting into my neck. And so the hoodie was coming down, and it was compressing the neck so hard that the hoodie actually caused microhemorrhages. So it's a type of bruising along that kind of pattern, kind of going down the neck here. And that was because the uncle was squeezing so hard, he was, the hoodie was digging into the patient's skin. And then of course he had a shirt collar mark. Shirt collar mark, classic child abuse finding too, is again from the back of the shirt digging into the skin. So this whole thing was just being compressed so hard. I mean, this really tells you how hard his uncle was squeezing his neck. And this is something you'll see if you do child abuse pediatrics too, where if the kid, say, is trying to get away from the adult and the adult's pulling the collar like this, the shirt collar mark will be on the opposite side. So you can tell which direction the kid was being pulled based on where the shirt collar mark is. So recap, again, those forms exist. I strongly recommend it. It's being used in multiple states now, and they're great forms. I'm not saying because I developed them, but it's developed by, it's like a clinician, forensic examiner, nurse examiner mentality of going through a logical systems-based approach, just like we do in virtually every other form of medicine, right? Systems-based approach, whether you're in GI, cardiac, whatever. It's a system-based approach, and it's a very logical progression, and it helps especially when you are interviewing a child or an adult who's had a brain injury, who can't remember the sequence of events correctly, or who has gaps in memory. Remember, if you're a nurse, you don't diagnose, you can screen positive for brain injury, then refer, just like the probably hundreds of patients are being screened for right now in stroke centers across the country using a similar assessment that's geared towards stroke, right? It's completely within your scope. And then just remember, case-by-case basis CTA. And that's not to say if in your clinical judgment, you want to do CTAs on the kids that you're seeing for strangulation, it's totally fine. It's within clinical judgment. It's just not the recommended universal screening like we do in the adults. So, and I apologize, I talked fast. Like I said, I have to run over that trial. So I know I went a little fast and there's a lot of topic information there, but I'm also a big Star Wars fan. If you guys haven't been to Disneyland yet, go. The Star Wars section is just breathtaking. You feel like you're in the movie. I swear I don't have any financial benefit. That's where I offload my secondary trauma. Take the kids to Disneyland and don't even research the rides. Just go on their site unseen. That's what I did. And I was so mind blown. So yeah. Any questions?
Well, Sean, thank you. That was an incredible talk. One of the questions that popped up in the chat kind of asked about using the Shasta as an EMS screening tool. Yes, I think you could use that as an EMS screening tool, but if you're thinking that you need to go through that, you need to transport this patient someplace to be evaluated, was how I would spin it. I don't know, Sean, how do you feel?
No, yeah, absolutely. 100%. And yeah, if you're out in the field like that and you come across this, yeah, just take them in to get them evaluated. Certainly, nobody expects you to have the time to kind of go through that. There is a first responders one that law enforcement uses, developed by Training Institute. And you could use that one too. You could use the Shasta technically, but yeah, just consider the fact that time. But even then, I totally agree 100% with Jeff. You just need to get them evaluated. If you think you need to use it, that's definitely a sign to bring them in.
Okay. And then for our child ready participants, I think we can make the website that you alluded to available so that people can download the addendums that you referenced, because they would be incredibly helpful to use.
Yeah, let me type it in the chat too. It's really simple. It's ccfmtc.org. And you just go to the section, the notes, the forensic medical exam section. There's the main section. There's a subsection where we were revising the notes, and we're still revising like the child abuse notes. Don't do those. Just go to the main section, and the 502, the domestic violence form, that's where the assessments are. We're going to add them to the child abuse form, but the child abuse form revision isn't finished. And so you can use the form from the DV form for all the other forms. So for example, all of our hospitals here and our SANE sites, all the SANEs have our 923, which is the sexual assault form. And behind it, they have the 502 DV assessments, strangulation and head injury. So even though it's part of the head injury form, it's not specific to only domestic violence. It can be used for anybody. You know, like I said, pediatric or adult or adolescent.
And again, just a huge thank you as someone who practices pediatrics, pediatric emergency medicine, and child abuse pediatrics. This is a topic that I feel woefully inadequate, you know, and so having you touch on this is just incredibly powerful and brings up a lot of things that I think we forget to think about and forget to ask.
Oh, thank you. I appreciate that. And thanks for the opportunity to teach. I love it.